Patrick Commiskey in Albuquerque, New Mexico. This is a patient. We are removing a astigmatism correcting lens in exchange for one that is straight monofocal. And we think that will give the patient a better quality of vision. You can see here actually on the capsule where the lens rotated post-op. You can see the sort of indentation on the capsule where the lens used to be, and then it rotated to another position. Now, why don't we just rotate it back in place? Well, things were never sharp for the patient, even right after surgery, before the lens rotated. Um, and we got some extra testing. We got a pentacam, and looking at the pentacam, there wasn't really a large magnitude of astigmatism, that is regular, straight up and down, left, right, that kind of thing, that lends itself well to an astigmatism correcting lens. Instead, what she had was a little bit of what we call posterior float elevation. Those are the earliest signs of keratoconus. Now, the patient is of an age where the keratoconus wouldn't really progress, but it does make the lens selection process a little bit more complicated. And in my experience, the patients with this tend to do well with a monofocal lens that doesn't have an astigmatism correction in it, and also doesn't have any extra extended depth of focus. Essentially, the cornea itself is multifocal because of this posterior float. So this is my preferred technique right here for um, the IOL exchange. Um, and essentially I'm going to cut this lens into 3 pieces. Why 3 pieces? Because I can still use the 2.2 millimeter incision that we used in the initial surgery. Now, I didn't do the initial surgery, but in our practice, they're 2 millimeter incisions, which is wonderful. So I like to just keep that small incision. I think it prevents complications, it's easier to manage, it's more comfortable for the patient. Um, so here we're just removing the remnants of that, of the lens there that didn't work well for her. And we're going to replace it with another lens. He actually saw me have a little bit of a hard time getting the scissors in the main incision. That's because I made my secondary incision immediately on top of the old one. I think it made a little bit of a false passage, so I had to kind of find the right passage through. Um, so we've got our monofocal lens all loaded up, and we're just kind of injecting it back into that bag, and we'll just open it up and send the patient on our way. Getting all that viscoelastic out. I tend to use OcuCoat as the viscoelastic of choice for the lens exchanges because it does a nice job of coating the endothelium and protecting it, but it's also not as difficult to remove as Viscoat is. So OcuCoat tends to be our viscoelastic of choice. Sorry again for the decentered video where it's a little bit off screen. Again, it's not off screen to me when I'm working, but doesn't make for a Hollywood perfect video. Anyway, just wanted to share that, the kind of lens exchange technique and kind of some of the things that we think about when we exchange lenses. Thanks for watching.